Now we are going to quickly revise renal physiology. So let's start. So first there is MCQ. Question is, which of the following glycoprotein is found in glomerular basement membrane? So the question is very specific. So here the question is asking about the glomerular filtration barrier. You know that in filtration barrier there are three layers. One is the endothelium cell of glomerular capillary. Second layer is the basement membrane. And the third layer of the food process of podocyte, right? So the podocyte. So these three are nothing but making a layer which is known as a glomerular filtration barrier. Now in all of these filtration barrier layer, there are presence of negative charge. So the negative charge is present here. Negative charge is also present on basement membrane, as well as the negative charge is also present on food process of podocyte. But here the question is asking that the negative charge on basement membrane is due to which protein? Although they are not saying negative charge, but this is the protein, the heparan sulfate. This is the glycoprotein which is responsible for negative charge of glomerular basement membrane, right? So the answer is heparan sulfate. So you look at quickly, you have to revise here. So endothelium cell of the glomerular capillary, it's a fenestrated type of capillary with a gap of 70 nanometer. Second layer is the basement membrane. It also contains little bit of gap which is 10 nanometer, and the food process of podocyte contain a gap which is known as slit pore. This slit pore is 25 nanometer, and we all know that the slit pore is not completely open. It contains a diaphragm, and this diaphragm also contains multiple opening which has a diameter of 4 to 14 nanometer. Now you look at, so this endothelium cell is lined by glycocalyx, GAG, glycosaminoglycan, and this is negatively charged molecule. The basement membrane is covered up by heparan sulfate proteoglycan, which is also negatively charged molecule. And the food process of podocyte also contain various glycoprotein which are negatively in charge. So that's why I told you that the glomerular filtration barrier contain negative charge not only on endothelium, it is also present on basement membrane, it is also present on food process of podocyte, right? And because of this negative charge on barrier, filtration barrier, what will happen? We know that if the molecule is positive in nature, it will be easily filtered through the barrier, and if the molecule itself is negatively charged, then it will be prevented from filtration by this negatively charged filtration barrier, right? So accordingly, we have classified the different substances according to their nature of filterability. Okay, we have classified the substances in freely filterable substances. So any substances which has a molecular radius which is lesser than 1.8 nanometer radius, these substances will be freely filterable at the level of barrier without any hindrance. What are the examples of those substances? Sodium, potassium, water, urea, chloride, glucose, sucrose, okay, glycol, inulin, all of them are freely filterable substances. Now, if the molecular radius is between 1.8 to 4.2 nanometer, then this molecule will be selected by filtration barrier that whether the molecule is going to pass through or not going to pass through. Okay, so they are known as the selective permeable substances. Who are they? Lysozyme, myoglobin, lactoglobin, egg albumin, Ben Jones protein, hemoglobin, serum albumin. All of them are in the range of selective permeable. So if the molecule is selectively permeable and if it contains a positive charge, if the molecule contains negative charge, if the molecule is neutral, no charge, then we all know that positively charged molecule will be filterable maximally greater than neutral molecule, which is greater than negatively charged molecule. Means if the molecule is negatively charged and if it is a selective permeable molecule, then the filtration of this molecule will be very, very low in comparison to positive or cationic molecule, right? And if the molecular radius is greater than 4.2 nanometer, then the molecule is not going to penetrate through the glomerular filtration barrier, which is impermeable, right? Got it. Now next is the glomerular filtration pressure and how that is causing filtration. Okay, so the question is, calculate the net filtration pressure in millimeter of mercury with the following data. So we know that glomerular filtration, okay, look at. So this is the afferent arteriole, this is the efferent arteriole. Glomerular filtration depends on 4 different types of pressure. What are these? What are this pressure? One is glomerular hydrostatic pressure, denoted by PGC, glomerular capillary hydrostatic pressure, right? So glomerular capillary hydrostatic pressure, PGC. Glomerular capillary, GC for glomerular capillary. Then this pressure is directed towards the Bowman's capsule, and the Bowman's capsule hydrostatic pressure is trying to oppose it. So Bowman's capsule hydrostatic pressure, suppose that is PGB, so it is trying to oppose the net filtration pressure. Plus, along with this, we also know that due to presence of plasma protein, capillary will have oncotic pressure. And oncotic pressure is a dragging kind of force, meaning it will try to drag fluid from Bowman's capsule. And the oncotic pressure of Bowman's capsule, suppose this is B. Okay, so this is not GB, this is Bowman's capsule. Sorry, so this is only B, PB. B stands for Bowman's capsule, right? So suppose pi B will try to drag fluid in this direction. So I can understand PGC minus PB plus pi B minus pi GC. This is the net filtration force calculation formula. So the net pressure is equal to this PGC minus PB plus pi B minus pi GC. So now we all know that this pi, or the oncotic pressure, this pi is nothing but the oncotic pressure. Oncotic pressure depends on amount of plasma protein. At the level of Bowman's capsule, the amount of plasma protein is very, very less, because filtration of plasma protein is not going to happen. That's why we assume that normally that this pi B is equal to 0. So basically, the net force of filtration is calculated by this formula, PGC minus PB plus, okay, pi B is equal to 0, so minus pi GC. So this is the net formula for calculation of glomerular filtration pressure. And in Guyton, it has been given that normal hydrostatic pressure, or PGC, is 60 mm of mercury. So in Guyton, it is given that this is 60 mm of mercury. Normal Bowman's capsule hydrostatic pressure is 18 mm of mercury, minus glomerular capillary oncotic pressure is 32 mm of mercury. So the net pressure of filtration is 10 mm of mercury. This has been asked in another MCQ, that normally what is the net force of filtration at the level of glomerular capillary? Your answer is 10, 10, 10. But the question here has been given a different data. So here the PGC is given 42 minus, okay, so this will be pi, okay, minus PBC, Bowman's capsule, is given 16 minus pi GC. This is the formula. So it is given 42 minus 16 minus 12. So obviously the answer is going to be 14 in this question. Got it? Very simple. So glomerular capillary hydrostatic pressure minus Bowman's capsule hydrostatic pressure minus glomerular capillary oncotic pressure. This is the net formula. We assume that the pi B, Bowman's capsule oncotic pressure, is 0, because protein filtration is almost negligible. Here it has been given with the following data, that assume that there is no protein were filtered, right? So that is the hint here in this question. You understood? Okay. Next is, which of the following is not involved in GFR autoregulation? So you know that there is something called autoregulation. What do you mean by that? Means certain organs in our body, okay, vital organs like brain, like heart, like kidney, they have autoregulatory capacity. What is that? The organ itself can regulate its own blood flow. So the autoregulation terms is related to constant maintenance of blood flow into an organ irrespective of your blood pressure change. That is the meaning of autoregulation. In case of kidney, the typical autoregulation curve that is drawn, it is given here. So look at here. So x-axis is the blood pressure. With the change in blood pressure, we can find out that initially there is rising of the blood flow into the kidney, but from a range of 70 mm of mercury up to this almost 200 mm of mercury, although the blood pressure is changing, but the renal blood flow or the renal plasma flow is not changing. So this is your autoregulatory range. So we say that in case of kidney, the autoregulatory range is 80 to 200 millimeter of mercury. Different books has given different value, but we will remember this 80 to 200 millimeter of mercury, or 220 millimeter of mercury. Okay. So this is the autoregulatory range. Now, when the blood flow is autoregulated, we know that blood flow autoregulation means your GFR, or the filtration pressure, will also remain constant. So your glomerular filtration rate, or GFR, will also autoregulated. So that's why we say that in case of kidney, because your renal plasma flow is autoregulated, GFR will also be autoregulated. Now question is, what is the mechanism of this autoregulation in kidney? So there are different mechanisms in different organ. Number one mechanism is myogenic mechanism. So from the name we can understand that this is a mechanism mediated by muscles. Which muscles? The smooth muscles of afferent arteriole. The smooth muscles of afferent arteriole is responsible for this kind of mechanism, and the mediator for this response is calcium, right? The second mechanism is known as tubuloglomerular feedback mechanism. So from the name we can understand that there is a feedback mechanism from tubules, renal tubules, up to the level of glomerulus. That is the meaning of tubuloglomerular feedback mechanism. This mechanism is operated by macula densa cell of macula densa cell of TAL, thick ascending limb of loop of Henle, and the mediator for this is nothing but adenosine. And the third mechanism, which has been included recently, that renin angiotensin aldosterone system, is the third mechanism for regulation of renal blood flow. So now if we go back to this question, which of the following is not involved in autoregulation? Myogenic mechanism, it's a true, responsible for the autoregulation. Tubuloglomerular feedback mechanism, this is also responsible, this is also responsible, but sympathetic is not. So our answer is sympathetic system. So sympathetic system, it can change the range of autoregulation. Okay, the curve will generally shift to the right side. Okay, what is the meaning of shifting to right side? Means range will be increased. The autoregulatory range will be increased in presence of sympathetic system stimulation. But sympathetic system per se is not a mechanism for autoregulation. Got it? So this way you have to remember that sympathetic system can increase the autoregulatory range, but it is not responsible for autoregulatory mechanism. Got it? Okay. So this is about autoregulation of GF. Now the next question is, tubuloglomerular feedback is for. So obviously tubuloglomerular feedback is for controlling the GFR. It is an autoregulatory mechanism for glomerular filtration rate. I told you that tubuloglomerular feedback mechanism will be activated when the macula densa cells is stimulated. So macula densa cell is the mediator. Again I am repeating. Okay, whenever macula densa cell is stimulated, it will release the adenosine. Okay, and this adenosine, with the help of the Lassus cell, is going to cause contraction of afferent arteriole, of the glomerulus, and by this way it is going to regulate your GFR, and this mechanism is known as the tubuloglomerular feedback mechanism. The detailed version of this mechanism has been discussed in main lecture. Okay. Now next is, apart from autoregulation, you know, the afferent and efferent arteriole constriction or dilatation can also changes the GFR. So this is one of the must know concept that you have to understand. So first you look at afferent arteriole. So if you causes constriction of the afferent arteriole, as it is shown in this diagram, so the resistance of the afferent arteriole is high. Whenever you causes constriction of the afferent arteriole, your renal blood flow will also decrease proportionally, and your GFR will also fall proportionally. Means more you constrict the afferent arteriole, more will be the reduction in the blood flow in the kidney, more will be the decrease in the GFR in the kidney. Okay, so that's why here in the x-axis you are saying that afferent arteriole resistance, more you increase the resistance of the afferent arteriole, what is going to happen? There will be more and more fall of renal blood flow, and there will be more and more fall of GFR also. This is the meaning. Very simple. Okay. Now the problem arises when the question is about the efferent arteriole. So if you causes constriction of the efferent arteriole, obviously there will be increase in efferent arteriole resistance. Whenever resistance increases, whether it is afferent arteriole or efferent arteriole, the blood flow has to be reduced. So look at here. Whenever you are increasing the efferent arteriole resistance, more and more increase in resistance of the efferent arteriole, more and more fall of renal blood flow is going to happen. More and more fall of renal blood flow is going to happen. But what will happen to GFR? GFR will increase initially. So when the constriction is mild, the GFR will increase initially, followed by there will be decrease in GFR when the constriction is severe, as you can find out from this curve. So efferent arterial constriction means GFR will increase when the constriction is mild. When the constriction is severe, then the GFR will start falling. Got it? So GFR has two effects. If the constriction of the efferent arteriole is mild, GFR will increase initially, followed by there will be decrease in GFR. Okay, that's why this you have to remember carefully. Okay, and if you causes dilation of the afferent arteriole, so GFR will increase, blood flow will increase. If you causes dilation of the efferent arteriole, your blood flow will increase, but GFR will fall. I hope you know. So you got the concept here that resistance, if you change, if the resistance is decreased, blood flow will increase. If you increase the resistance, blood flow will decrease. But GFR, you have to think and then you have to answer. Like for example here, GFR is increasing initially, followed by there is decrease in GFR. There is a reason for everything, but in quick revision, I'm not going to give you the explanation. Okay. Now next is question about the tubular functions. So the question here, in the proximal convoluted tubules or in PCT of kidney, luminal concentration of which of the following will decrease? All of the following will decrease except. So the question is very critical. Okay. So except is the question. The luminal concentration of all of the following will decrease except. That means they are asking which of these following substances will have their increase in concentration at the end of proximal convoluted tubules. So look at. So if this is the proximal convoluted tubules, right? We know that there will be freely filtration of the sodium, there will be freely filtration of the chloride, there will be freely filtration of the glucose, there will be freely filtration of the amino acid. So amino acid, glucose, all of them will be freely filtered. Now then what is going to happen? We all know that at the level of first part of the proximal tubule, almost all the amino acid, almost all the glucose is going to be reabsorbed, and how much? Almost 100%. 100% reabsorption is going to happen. So immediately the level of this glucose, level of this amino acid will fall at the end of proximal tubule. So it is level is decreasing. So it is not my answer. What about bicarbonate? Bicarbonate is also freely filterable substances in the proximal tubule. In the first part of the proximal tubule, you know, the sodium which has been filtered, that sodium is going to be reabsorbed. But how this sodium reabsorption is going to happen? This sodium reabsorption happens along with the glucose, along with the amino acid, along with bicarbonate. So in the first part of the proximal tubule, the hugely filtered sodium will be reabsorbed along with bicarbonate. So sodium and chloride, they has been filtered equally. Okay. But with this sodium and chloride, you are picking up the sodium along with bicarbonate, not with the chloride. So what will happen? You are leaving the chloride alone in the first part of the proximal tubule. So what will happen? The chloride concentration will gradually increase towards the end of the proximal tubule. Later on it will be absorbed, okay, in different parts of the nephron. But if you look at the end of the proximal tubule, the chloride concentration will be increased a little bit, because in the first part, sodium is reabsorbed more along with bicarbonate, leaving behind chloride. So answer here in this question is chloride. Bicarbonate level will also decrease. Got it? AIIMS entrance question. So very tricky question. Got it? Okay. Now next. ADH regulate which of the following aquaporin? We all know that ADH, that is the anti-diuretic hormone, or ABP, you say, it has main effect or only effect on aquaporin number 2. Aquaporin 1, aquaporin 3, aquaporin 4, they cannot be stimulated by ADH hormone, right? So answer here is aquaporin 2. What is the speciality of this aquaporin 2, which is not there in case of aquaporin 1, 3 and 4? So you know that the ADH has action on which part of the nephron? ADH causes reabsorption of water. In which segment of the nephron? You know, it is mainly at the level of distal tubule, particularly at the level of collecting duct. So, collecting duct, suppose this is the luminal membrane of the collecting duct and this is the basolateral membrane of the collecting duct. You know that ADH has its receptor on this basolateral membrane, and which receptor? This is V2. So, ADH will stimulate this V2 receptor, and in presence of stimulation of this V2 receptor, there will be increase in 1 second messenger system, that is CMP. Now this CMP is going to stimulate the vesicles which are present inside the cell. What is the importance of this vesicle? The vesicle contain one typical aquaporin, and this is the aquaporin 2. Other aquaporin, like for example aquaporin 1, 3, 4, all of them, they normally present on the cell membrane. They don't present inside the vesicles. They always present on the cell membrane. So this is aquaporin 3, okay. Aquaporin 4, they are constitutively expressed on cell membrane. So ADH cannot stimulate them. But aquaporin 2, normally when the ADH is not there, it will remain inside the vesicle. Then ADH will stimulate the vesicle. Vesicle will move towards the membrane, and then the aquaporin 2 will be inserted at the level of this cell membrane. So this is aquaporin 2. So aquaporin 2 will only be inserted on the apical membrane of the collecting duct cell when the ADH is present. Okay, so please note down, aquaporin 2 is present on the apical membrane or luminal membrane of the collecting duct cell. Basolateral membrane contain aquaporin 3 and 4, but ADH has only action on luminal aquaporin, that is the aquaporin 2. Although the receptor of ADH is present on the basolateral membrane, so how the ADH is acting on luminal aquaporin? It is acting via a second messenger, that is CMP. All of them has been asked in MCQ in different type MCQ. So please note down. So whatever we have discussed here, it is written here that ADH inserted aquaporin 2 on luminal membrane of the collecting duct epithelium cell. Aquaporin 3 and 4, they are the constitutively present on basolateral membrane, and they are not regulated by ADH. This is the information that you have to remember in your brain. Got it? Okay. Now next, impaired function of aquaporin causes which are the following? We all know that ADH, if it is secreted in lesser quantity from the CNS, then that is also diabetes insipidus, but that is central diabetes insipidus. But if the ADH is not capable of acting at the level of V2 receptor, then that is nephrogenic diabetes insipidus. So here the question is asking about impaired function of aquaporin causes which of the following? Your answer is nephrogenic diabetes mellitus. So when the ADH is not able to act on the V2 receptor, the aquaporin 2 will not be able to function properly. The aquaporin 2 will not be able to insert it into the membrane, and that is nephrogenic diabetes insipidus. We all know that this is Liddle syndrome, Bartter syndrome. This is due to different ion channels. The detailed version I have discussed in my main lecture. Okay, so for the timing, you remember this nephrogenic diabetes insipidus. So it is said that whenever the ADH functions is decreased 70% or more, okay, either due to problem in secretion or due to problem in action of ADH, then the disease is known as the diabetes insipidus, right? So if the problem is at the level of secretion or synthesis, okay, primary deficiency of ADH result from agenesis or irreversible destruction of the neurohypophysis. We all know the neurohypophysis is the posterior pituitary, right? If there is agenesis or there is irreversible damage of the posterior pituitary, then ADH secretion will be lesser. It is decreased more than 75% of the normal, then that is central or neurogenic diabetes insipidus. But when the ADH is secreted normally or maybe a little more than normal, but due to mutation of the V2 receptor, the ADH is not able to act on the collecting duct cell, then that disease is known as the diabetes insipidus, but nephrogenic diabetes insipidus. So this much of information you have to remember, at least for physiology, right? Okay. Now next is another important topic in renal physiology, that is the JG apparatus. So all of you know that the JG apparatus consists of three components, three part. Okay. So one is JG cell. So look at here in this diagram. So this granular cell, what is written here, this is nothing but JG cell. So JG cell is also known as granular cell because it contains renin containing granules. Okay. So JG cell, juxtaglomerular cell. Where they are located? Look at here. It is located at the level of afferent arteriole. Got it? Okay. Then second is macula densa. So it is a basically distal tubular cell. But exactly the answer is macula densa is the cells of TAL, thick ascending limb of lobe of Henle. If it is not given, then your answer will be TAL DCT junction. Okay. Please note down. It is the cells of TAL. And in between this distal tubular nephron and this afferent and efferent arteriole, there is presence of another cell here. This cell is known as the Lassis cell. So this cell is known as the Lassis cell. It is an anti-inflammatory cell. So what are the three components of this JG apparatus? JG cells. We say that JG cells is nothing but it is the modified smooth muscle cells of afferent arteriole. Very, very important. Afferent arteriole. And this is the cell which contain renin containing granules. So renin secretion is a function of this cell, right? Second is JG cell also acts as an intrarenal baroreceptor. It can also sense as blood pressure. That's why it is known as JG cell is also known as intrarenal baroreceptor cell. Second, macula densa cell. I told you that macula densa cell, it's a kind of chemoreceptor cells, and it is located at the uppermost part of TAL, thick ascending limb of lobe of Henle. If TL is not given in the choices, then TAL DCT junction will be your answer, but not the DCT. Okay. Now, whenever I am saying chemoreceptor cells, which chemical it can senses? It can senses sodium as well as chloride load in the distal tubular lumen. Okay. And whenever macula densa cell is stimulated, the transmitter, okay, or the mediator which is released by the cell is adenosine. I told you earlier that this macula densa cell is responsible for tubuloglomerular feedback. Got it? Okay. Now the last one is the Lassis cell. This is also known as extraglomerular mesangial cell. And this is an anti-inflammatory cell. So these are the important things that you have to remember about JG apparatus. Got it? Okay. Very good. Now next is one calculation you have to do with respect to tubular function. So here calculate the GFR from that. Oh no. This is a separate question. So here you have to calculate the GFR. So we all know that there is something called clearance. Okay. The formula of clearance is equal to UV upon P. So what is U? U is the urinary concentration of the substances. So here it is given urine concentration is 100 milligram per ml. That is U. Then V is the urine flow rate. Okay. ml per minute. That is the V. And plasma concentration is P. Right. So these are the three parameters. Now, if you measure the clearance of inulin, so we all know that these two information, clearance of inulin, okay, is equal to GFR, and clearance of para-aminohippuric acid is equal to renal plasma flow. These two important information you have to remember. Sometimes rather than inulin, we also use creatinine for the surrogate of GFR, but for calculation of the renal plasma flow, clearance of PAH is used. So here it is given that urinary concentration of inulin is this, plasma inulin concentration is this and urine flow is given. That means I have to calculate the clearance of inulin and I am going to get the GFR. So how to calculate? You apply this formula, very simple formula. Before applying the formula, you just check whether all the units are in the same or not. Whether all the units are in ml or in dl. If it is in dl, deciliter, then you have to convert into ml. Okay, 1 deciliter is equal to 100 ml. So here all the units are same. So U is 100, right? V is 1, P is 2. So obviously 100 upon 2, that is 50 ml per minute. This D is the answer of this question. So calculation of GFR based on your clearance formula. Simple? Okay. Now next is, okay, so this is one of the tricky question. The main ion in thick ascending limb of loop of Henle responsible for reabsorption of divalent ions from the lumen. Very, very critical, tricky question, I would say. So they're asking that at the level of TAL, thick ascending limb of loop of Henle, we normally know that this is the segment where your furosemide diuretics, Lasix diuretics is going to act on a transporter. That transporter is known as NKCC, sodium, potassium, 2-chloride channel, right? So look at what is happening at the level of TAL. So suppose this is one TAL cell, thick ascending limb of loop of Henle cell, and this is another epithelium cell, right? And this is the luminal side, and this is the basolateral side. So you all know that whatever amount of sodium, chloride or other divalent ion like calcium, magnesium has been reached at the level of lumen of this TAL, they are going to be reabsorbed at the level of TL in significant amount. We say sodium reabsorption is around 25 to 30% here. So how this reabsorption is going to happen? We know that the main transporter which is going to pick up the sodium along with potassium along with 2 chloride. So sodium, 2 chloride and 1 potassium. This is the transporter which is known as NKCC. This is known as NKCC, sodium potassium chloride channel, right? After reabsorption of all of this, the potassium will diffuse back into the lumen again with the help of a potassium channel which is present here, which is known as ROMK type of potassium channel, renal outer medullary potassium channel. Got it? So whenever you were picking up 1 molecule of positive charge sodium, 1 molecule of potassium charge positive ion potassium and 2 molecule of negative charge chloride, the luminal charge is not going to be disturbed because you have picked up 2 positive and 2 negative charge. But whenever you are returning back this positive ion potassium into the lumen, what will happen to the luminal charge? The luminal charge will be positive. So this diffusion back of potassium causes lumen positivity. Lumen positivity. Now, if the luminal charge is positive, what will happen to the other positively charged ion? They will be attracted towards the lumen or they will be pushed out of the lumen. Obviously, it will cause repulsion of the other positively charged ion. That's why the other positively charged ion which are present in this segment, like for example, calcium, magnesium, okay, it will be pushed out of the lumen. How it will be pushed? It will be pushed through a pathway which is present in between 2 cells. This pathway is known as the paracellular pathway. This is known as the paracellular pathway, right? So with the help of this paracellular pathway, the calcium and magnesium will be pushed out of the lumen. That means there will be reabsorptions of calcium, there will be reabsorption of magnesium at the level of this thick ascending limb of loop of Henle due to this lumen positive charge. Who is giving this lumen positive charge? The potassium. That's why we say that if the potassium is not diffusing back into the lumen, the divalent ion like calcium, magnesium reabsorption will be decreased. That's why if you block this NKCC transporter by furosemide, your calcium, magnesium reabsorption will be decreased. Okay, because if you block this, then sodium potassium chloride is not going to enter in the cell, and if they are not entering, then potassium will not diffuse back into the lumen, it will remain in the lumen. So that's why we all know that furosemide diuretics which block this NKCC transporter is responsible for decreased calcium and magnesium ion from the TAL. More amount of calcium and magnesium will be lost in the urine. Please note down that this paracellular pathway is responsible for reabsorption of very huge amount of magnesium here. It is said that 70% of the magnesium reabsorption occurs at the level of TAL, and around 20 to 25% of the calcium reabsorption occurs at the level of TAL by this paracellular pathway. Paracellular pathway is always passive reabsorption, right? Got it? So this is the mechanism which has been asked in this question, that the main ion in thick ascending limb of loop of Henle responsible for reabsorption of the divalent ion from the lumen is nothing but your diffusion back of potassium, right? I hope all of you remember that this is the segment TL where mutation of this NKCC is responsible for the disease. What is the disease? The Bartter syndrome, okay? Bartter syndrome type 1, Bartter syndrome type 2, ROMK. So this is the segment which is very, very important for your MCQ, okay? So in the main lecture, you have to read the detailed version of this, okay? Next is calculate the urine glucose in a diabetic person. The GFR is given this and blood glucose is given. So this is the question where the tubular functions you have to calculate. So try to answer the question or try to understand the topic like this. So this is your Bowman's capsule with proximal convoluted tubules, and we know that at the level of Bowman's capsule the capillary blood flow is happening. So suppose this is afferent, this is efferent. Blood glucose amount is given 200 milligram per dl. First of all, you convert this dl into ml. So 200 milligram per dl means it is 2 milligram per ml. Okay, and then it is said that the GFR, okay, mean filtration of the plasma in 1 minute is how much? 90 ml per minute. So I can understand from this that within 1 ml of plasma 2 milligram of glucose is present. If there is filtration of 90 ml of plasma, how much glucose will be filtered? That is a simple thing. So GFR is 90 ml. What is the meaning of that? Means there is filtration of 90 ml of plasma in 1 minute. Ultrafiltration of plasma, and 1 ml of plasma contain 2 milligram of glucose. So how much will be the total amount of glucose in 1 minute at the level of this Bowman's capsule? So this is nothing but 180. How 180? So 1 ml plasma contain 2 milligram glucose, 90 ml plasma will contain 2 into 90. So this way we have got 180. That means this 180 milligram glucose that has been filtered at the level of Bowman's capsule, this amount is known as tubular load. So this is known as tubular load, means how much is the total amount of load on tubules. So how we are going to get this tubular load? We have to just multiply the plasma concentration of the substances with GFR. This is the formula for getting tubular load amount. Now within this tubular load, we all know that glucose is going to be reabsorbed with the help of transporter protein, that is SGLT. And the amount of glucose that has been absorbed in these cases is given is 150 milligram. Okay, that is known as the maximum amount of glucose that is being reabsorbed by tubule is Tmax, total maximum amount of glucose reabsorption. So total 180 milligram of glucose has been filtered. Within that 180 milligram you have reabsorbed 150. How much glucose will remain? The remaining glucose will appear in the urine, and that is nothing but 30 milligram per minute. Got it? So this is the way how to answer the question similar to this kind of MCQ, right? Okay. Next is, so we have just discussed that glucose reabsorptions occur with the help of SGLT. Now we have to remember one important thing. Glucose reabsorption occurs in the early part of the proximal tubule also and late part of the proximal tubule also. early part of the proximal tubule is known as the proximal convoluted tubules, and late part of the proximal tubule is known as the proximal straight tubule. Proximal straight tubule, right? Maximum glucose reabsorptions occur in the proximal convoluted tubule, 90%, and little amount of glucose, that is remaining 10% reabsorption, occur in the proximal straight tubule. Both of them are part of the proximal tubule only. So proximal tubule reabsorb 100% of glucose, but first part of the proximal tubule 90%, later part of the proximal tubule 10%. In the first part, the transporter which is present is, see here, SGLT2. In the second part of the proximal tubule, the transporter is present, SGLT1. Right? So, major glucose reabsorption in the kidney is done by SGLT2, that is the 90%. And 10% glucose reabsorption occurs by SGLT1, that is in the proximal straight tubule. Now, sometimes they also ask that this SGLT2 and 1, what is the coupling ratio? Means these are the symporter. Symporter means glucose will be reabsorbed along with sodium. Now, look at here. SGLT2, it reabsorbs 1 molecule of glucose, 1 molecule of sodium. 1:1 is the ratio. But SGLT1, it reabsorbs 1 molecule of glucose with 2 molecule of sodium. Okay, so 1:2, 2:1. That is the coupling ratio. So SGLT2 means ratio is 1:1. SGLT1 means 1:2. Okay. Now, these are the transporter which are present on which side of the cell? It is present on the luminal side of cell. At the level of basolateral side, the transporter for glucose reabsorption is different. At the level of basolateral side, for proximal tubule, the transporter is GLUT, GLUT2. Look at here, GLUT2. And in case of proximal straight tubule, this is GLUT, GLUT1. So here, this is GLUT1. So if it is SGLT1, it will be coupled with GLUT1. If it is SGLT2, it will be coupled with GLUT2. GLUT2, these are the examples of facilitated diffusion. So if the question is transporter in the basolateral aspect for glucose reabsorption in the kidney, facilitated diffusion. But this SGLT1 and 2, they are the part of the secondary active transporter system. Got it? So this is very, very crucial thing that you have to remember. Okay. Next is counter current flow. So counter current flow means, there are 4 criteria that should be met. What are those 4 criteria? There should be 2 tubes which are parallel to one another. This tube should be very close to one another. So the tube should be very close to one another. The flow, of fluid in this tube should be opposite to one another. If the flow is downward here, it should be opposite. And the tube should be selectively permeable for different substances. Means if it is permeable to water, then this should be impermeable to water like this. Selective permeable. If this kind of arrangement is present in any part of the body, then we say that counter current flow is happening. What are the examples? Intestinal villi, skin, testis, kidney, including your lungs. All of this area has the counter current system or counter current flow. This has been asked in MCQ. Now, in case of kidney, the counter current system has 2 parts. One is counter current multiplier and one is counter current exchanger. Counter current exchanger happens at the level of vasa recta, right? And counter current multiplier, the loop of Henle is also responsible for this loop of Henle, as well as the medullary collecting duct is also responsible for counter current multiplier. In case of loop of Henle, which part of the loop of Henle? The thick ascending limb of loop of Henle is the main part for counter current multiplier, although ascending thin segment of loop of Henle is also there. Medullary collecting duct is also important because this is the segment from where urea reabsorption is going to happen. And from the level of TAL, sodium and chloride reabsorption is going to happen. So basically, if you look at counter current system, what the counter current system is doing? Counter current system is responsible for increasing the tonicity of the medulla, increasing the tonicity of the medullary region of the kidney. Why? If you increase the tonicity, what will be the help? The help will be that there will be increased reabsorption of water from urine. So your urine will be concentrated if you increase the tonicity of the medullary region of the kidney. Now, how the tonicity is increased? What mechanism? The mechanism is known as multiplier. So multiplier is responsible for generation of the hypertonicity of the medulla, and countercurrent exchanger is responsible for maintenance of the hypertonicity of the medulla. And what are the substances that is making this medulla hypertonic? 3 substances. Who are they? Sodium is responsible for increasing the tonicity of the medulla. Chloride is also responsible for increasing tonicity of the medulla, and urea is also responsible. It is said that the maximum tonicity of the medulla that can be reached is approximately 1200 milliosmol per liter or to 1400 milliosmol per liter. 1400 milliosmol per liter. Within this 1200 milliosmol per liter, it is said that 50 to 60% contribution is done by sodium chloride and 40 to 50% contribution is done by urea alone. Okay, so sodium chloride in combination for 50% to 60%, urea alone for another 50%. So if I divide this 1200, so 600 milliosmol is due to sodium chloride in combination, NaCl in combination, and 1600 is urea alone. But if you separate this sodium and chloride, so sodium and chloride you have separated. So sodium will be responsible for 300 milliosmol per liter, chloride will be responsible for another 300, and urea will be responsible for 600. So if the question is like this, that which of the following is the most important substances for medullary hypertonicity? Sodium, chloride, or urea? Your answer will be urea. But if sodium and chloride is given as a combination, sodium and chloride both, then that is the more important than urea alone. Okay, but if sodium, chloride, and urea given as 3 separate options, then urea is the single most important substances. Got it? So this is all about which you have to remember about countercurrent system. So the MCQ related to this system, the primary driving force for countercurrent multiplier system. Multiplier, I told what is the main segment. The main segment is the TAL. At the level of TAL, which transporter is there? NKCC. NKCC reabsorb what molecule? Sodium molecule and chloride molecule. So reabsorption of sodium in the thick ascending limb of loop of Henle. This is the main segment. This is the primary driving force for countercurrent multiplier. Okay, next question. Which of the following is not a component of countercurrent multiplier mechanism? So the question is about multiplier. Vasa recta is not responsible for multiplier because this is countercurrent exchanger system, right? So this is all about the renal physiology in brief. You have to read at least this much of information.